Good afternoon, everyone, and thank you so much for joining us for our fourth READI Special Populations Roundtable Talk. Today, we'll hear from Dr. Prakash Ganesh about rural communities through a global context and through the lens of Cuyahoga and Summit counties. But before we do, I'll share a bit about the CTSC. The Clinical and Translational Science Collaborative of Cleveland is a collaborative among Case Western Reserve University and its affiliated hospital systems, the Cleveland Clinic, Metro Health, University Hospitals, and the Lewis Stokes Veterans Administration Medical Center. We aspire to be a catalyst for high-quality clinical and translational research, both locally and nationally, by changing the culture and environment of biomedical research, sharing resources and expertise, and streamlining the research process to move translational research from bench to bedside into the community. Dr. Prakash Ganesh was born in Mission, British Columbia, Canada, and raised in California. He has earned 4 academic degrees, including his MD from Ben Gurion University Medical School for International Health in collaboration with Columbia University in Be'er Sheva, Israel, and his Master of Public Health from the Case Western Reserve University School of Medicine. Dr. Ganesh completed a combined residency in family medicine and public health and general preventive medicine at University Hospitals Cleveland Medical Center in Cleveland, Ohio, and he is board certified in both specialties. Following residency, he moved to Malawi from 2015 through 2019, where he worked in a large refugee camp, provided inpatient care at a tertiary hospital, and worked for the Lighthouse Trust through the International Training and Education Center for Health, ITEC, at the University of Washington. While at the Lighthouse Trust, Dr. Ganesh supervised clinicians in providing HIV and tuberculosis care, provided direct clinical support for the National Tuberculosis Program, and also participated in various task forces for the National HIV Program and the National TB Program. In addition, he worked as a clinical instructor and lecturer at the Malawi College of Medicine. Dr. Ganesh is currently an assistant professor in the Department of Family Medicine and Community Health at University Hospitals Cleveland Medical Center and in the Center for Community Health Integration at Case Western Reserve University School of Medicine, the latter of which promotes research and development for community health and integrated personalized care. He is also the Preventive Medicine Residency Associate Program Director at University Hospitals Cleveland Medical Center for the Categorical and Combined Family Medicine/Preventive Medicine residencies, teaching medical students and residents. Dr. Ganesh is currently practicing at Neighborhood Family Practice, a federally qualified health center located on Cleveland's West Side. Among his focus areas are HIV, hepatitis C, refugees, and global health. Certified as an American Academy of HIV Medicine Specialist, Dr. Ganesh is also a multi-drug resistant TB clinical consultant for the Stop TB Partnership and United Nations Office for Projective Services. All right, Dr. Ganesh, you may begin your presentation.
Thank you. Thank you for the introduction. Let me just pull up my slide deck here. Sorry, it's like. You guys can hear me okay?
Perfect.
And that looks okay. All right. Thank you. Yeah, so I just wanted to speak briefly about the challenges that we are facing locally and bring in some of my global health experience in working with rural populations and in rural health. As you know, in Cuyahoga County, we're not specifically a rural county. And recently in 2020, the ODH published through the Office of Rural Health, they published a report, I think it came out in June 2021. They were sharing kind of their strategies and goals. They basically had done a needs assessment for rural healthcare. And with that, they had defined what they were going to use as what is considered rural health. And as you know, we do have Appalachian counties as well. So this is a diagram showing all of our counties. in terms of rural and Appalachian and our urban counties. Us here in Cuyahoga and Summit are not really considered rural counties, but we do have some parts that are would be considered rural. But the goal of this Ohio Health Improvement Plan that was published 2 years ago now was to develop a rural health plan for rural providers so they can have evidence-based or could make evidence-based decisions to improve some of the rural health in Ohio. And what they considered rural were counties that had no urbanized areas or clusters and were adjacent and not adjacent to metropolitan counties and were less than 50,000 people. Places that they considered partially rural were considered places that were next to a metropolitan county. And then we have our Appalachian counties that are kind of on here on this east side. So Ashtabula, Trumbull, Mahoning in Northeast Ohio would be, and Columbiana would be considered those. And I just kind of wanted to step back though, since we're working through the CTSC here, and talk about briefly about health disparities and the social and economic inequities that we do see. A lot of my conversation revolves mostly looking at Cuyahoga County, but a lot of it we still see in a lot of our rural communities as well. So all of our social determinants of health with a baseline, unfortunately, a baseline of racism and discrimination. And I know Dr. Heidi Gullett will be leading a group today looking at the public health's response to racism as a public health crisis. But these other social determinants of health, when I teach at the medical school, I usually talk about the introduction to public health. This is one of my slides, but try to emphasize that a lot of what we do in the healthcare system is way out here. And they have the Kaiser Foundation does have several other diagrams that show how little impact our healthcare system has compared to all the other social determinants of health on a person's health and well-being in the end. And looking at the leading causes of death in 2019, and this was published in the report that they submitted in 2021, we see it's stratified by location and what kind of communities people live in. You see that Appalachian and rural counties are hit pretty bad in terms of death rates due to heart disease. Looking at cancer death rates for all types of cancer, you see our rural and Appalachian counties are also hit pretty hard. Accident death rates also very high. And then also our chronic lower respiratory diseases, COPD, for example, asthma, also are very high in these rural and Appalachian counties. The places or the rural and Appalachian counties did well or better in terms of death rates was in terms of strokes. But I didn't put all the leading causes of death, but those were the top four that I put up there. But everything else was in rural and Appalachian counties that were hit the hardest. Some of you may have seen the CHIPS and CHINA acronyms here before, but the CHIP is basically the Community Health Improvement Plan, and the CHINA is the Community Health Needs Assessment Plan. And then there was also Ohio Rural Health Meeting that took place that had providers from rural communities kind of map out what their healthcare priorities were. So this is input from public health, major hospital systems, and rural health providers. And a lot of the patterns that we do see were pretty common between all of them. We see substance abuse as a priority, obesity, mental health, behavioral health, which I still think is pretty consistent with what we're seeing in urban settings, substance abuse. And then what underlines a lot of these is access to care. And access to care can mean a variety of things. And I don't want to say it's just being able to get to their doctor, but it's more complex We have to look at availability of providers, affordability, um, and working at a FQHC. That's usually one of the challenges that I face with a lot of my patients. Accessibility, which is a lot of, if you've been trained in ECHO and the ECHO series that was developed around hepatitis C in New Mexico, a lot of the challenges that they faced was getting access to Hep C treatment with specialists or hepatologists or infectious disease doctors in a urban setting when most of the population lived in very rural areas, or where the population that had hepatitis C was outside of Albuquerque in this example. And so I am also part of a Hep C training program that is trying to train providers in Ohio, primarily PCPs in Ohio, to treat Hep C. And that could hopefully increase accessibility to Hep C treatment in a lot of our more rural communities. Availability, being able to accommodate patients' needs, and then acceptability. And that was something that that we've been seeing a lot more highlighted in the LGBTQ community because of lack of inclusive spaces that we are seeing in various communities. But then also, as I said before, like for example, the Hep C treatment, we do have a lot of lack of specialist providers. And then another thing that was highlighted in that report is the lack of trust in the healthcare system. What we also do through the health department is we do support a lot of follow-up of syphilis cases, HIV cases, where a lot of the health departments in these other more rural and Appalachian counties are minimal. So we do support a lot of the disease investigation that we do for syphilis, HIV. If you don't know, there's a really high increase of syphilis cases and congenital syphilis cases throughout Northeast Ohio. So ODH, or the Ohio Department of Health, has helped support our county hire more disease investigation specialists that are out in the field and located here in the office that go and follow up these cases of new cases of HIV and new cases of syphilis specifically, and make sure they get treatment. So they help support a lot of our other counties that are neighboring us that may not have as much staff and resources to chase people. We also include a lot of these counties in our, we do have a congenital syphilis board that meets, and they go over any new cases of congenital syphilis that have been identified within these counties. And the same goes for HIV in terms of making sure that patients are not lost to care or connected to care, and so on. Which brings me to what I did in Malawi. So as Jalise said, I worked there from 2015 to 2019, and a lot of the issues that we faced was access. Malawi, for those that you may not know, is located here where the red circle is in sub-Saharan Africa, and it's a landlocked country, one of the most poor in the region, but it does have a very large lake. A lot of the community lives rurally. We lived in the capital, and the work that I did was mostly in the capital in Lilongwe. But things got very rural very fast. Probably, I think 80% of the country lives rurally. A lot of the people are farmers, and they are subsistence farmers, so they get hit very hard when there's drought or flooding. I think recently there was just a New York Times article that came out talking about some of the cyclones that have hit and have devastated a lot of the farms there. So there's a lot of hunger. There was cholera, and that was also, I think, in the New York Times not too long ago, a few months ago now. But I primarily worked in HIV and tuberculosis, and a lot of these new infections occurred in the more rural communities as well. And so, especially tuberculosis, where people were living a lot closer together. Just to give you a little bit of epi around Malawi, it is there is around 19 to 20 million people now. Life expectancy is much lower. Infant mortality rate is about 27 to 100 live births. In the US, it was nationally, it was 5 per 1,000 live births. And what they have done to kind of address the gap in care that they see in the community is created a public, and the resources that they have is created a public health approach to addressing these needs. They have a lot of shortage of providers, especially out in rural settings. So they do have central hospitals that are located. There's only 4 located throughout the country, and they're mainly in the main hubs of the county. And then each district has a district hospital, which can support minor surgeries, C-sections, and they could provide HIV care there. They usually have a TB ward and some other, they have few doctors, maybe 1 or 2 doctors, and mostly they have a administrative role. And most of these are straight out of medical school usually. So have very little clinical experience, but they are manned by clinical officers. And that's kind of what Malawi has done to address the lack of providers that they have in the country. And then you have local healthcare centers that are split, that can be almost anywhere, and they have private hospitals as well. And this was done to help provide equitable access. All this care is free of charge outside of the private hospitals. This was used to expand coverage and provide some kind of similar levels of care, but we can go into that in another lecture. But a lot of this was done to help task shift the lack of providers and resources that is seen throughout the country. And this is just another diagram showing kind of how our central district and community hospitals is split up. Oftentimes in global health is described as this pyramid type of scheme. And then another facility I worked at was the Dzaleka refugee camp, which also had very little resources, no running water, no power. And most of the community was living in mud huts. UNHCR did help support a lot of the activities that went on here. But in general, Malawi wasn't very supportive of the refugee camp. A lot of people had lived there and grown up there, lived there for 10, 15, 20 years before relocating to another country. But most people were coming from Rwanda, the DRC, Burundi, some economic refugees from Ethiopia. But Malawi didn't really let them integrate into Malawi. A lot of them had to live in the camp. If they were found outside the camp without the proper documentation, they could go to prison and then be deported. And this is what the camp looked like. As you can see, there's no power lines, no roads. So in the rainy season, a lot of this is flooded. You can see that most of the roofs are thatched. They did have a healthcare center that I helped support while I was there. And I did end up having a clinic there as well. But just back on this healthcare center, a lot of the refugees did have a lot of mistrust, as I described, and that was found in the needs assessment in our rural needs assessment for Ohio. They had a lot of mistrust in the healthcare system. Refugees didn't trust the healthcare system or feel that they were being treated appropriately, oftentimes when they went to this center. In my clinic, I usually was by myself with a translator, but I brought my own medications and diagnostics that I could. I did home visits for patients that could not get to me. And then, and those were usually people that suffered strokes or had some kind of physical impairment that made it difficult for them to get to me. And then I also supported the main central hospital. And just to share a few images of what the capital city, I mean, it was still pretty rural in a lot of senses, but this is what a ward looked like. People, this was the hallway, and you can see there's no power here, and it's open to the elements. So if people needed oxygen, they had to be in another room because they couldn't be in here. And this was an inpatient ward. This is what the pediatric ward looked like. As a family physician, I also supported a lot of the pediatric wards, especially with HIV consultations. And this is kind of typically what you would see in the wards with parents or guardians with the child. And then here's I would also support the NICU, and this is 3 children, you can see here, receiving oxygen treatment on this one incubator. But yeah, that was just a very brief kind of overview of what we've been seeing. I believe I had 15 to 20 minutes, correct?
Yes, that was perfect, Dr. Ganesh. Thank you so
Okay.
much. I see
But
we have a couple of questions in the chat.
Mhm.
Anita, if you'd like to come off mute and ask, you're welcome to.
I'm sorry. I see
Sorry,
it here.
sorry, I'm here. Give me 1 second. Let the light, there we go. So I'm just curious, I mean, my experience of Appalachia, just my parents, were born in the Alleghenies in Pennsylvania, but it's sort of, remote and rural, and people don't trust any federal agencies. It's really, that's like pretty normal for rural groups. And I see or have seen a lot of like alcohol and tobacco use. And I'm just wondering what else you think contributes to the health disparities? Like, do you think those 3, mistrust of federal agencies, and then like I know, for example, that in my parents' old town now, there have been, the opioid crisis hit them, the meth labs hit them,
Yeah.
all of that stuff kind of hit the rural areas.
Yeah, I think it's multifactorial. I don't think it's just a mistrust that we see. I think it's also the education.
Okay.
I mean, if you look at the demographics of a lot of the rural and Appalachian counties, there are differences that you see in terms of, I had it here, of just a lot of indicators looking at the population, like how much education there is, how much are college educated. I have it pulled up here that they have higher rates of persons in poverty. Population density is much lower. Insurance coverage is actually lower as well. And then also the amount of median household income is much lower as well. So I think a lot of these demographic factors probably are related to the smoking and alcohol use that you asked in your question as well. But also, I mean, I think I wouldn't say it's all the healthcare system's fault or just the mistrust in it, but I think it could be generational as well.
Yeah. Okay. Thank you. Appreciate that.
Sorry, I was jumping around a lot because I was trying to cover a lot of things. But what I was sharing about what our experience has been in rural health was mostly in terms of what we've seen in Cuyahoga County and some of our neighboring counties. And we're not as rural as some of our Appalachian counties that we see here. So we hear it from some of the other county medical directors and health commissioners, but we are not handling that as much
Thank you.
on our own.
Dr. Ganesh, could you tell us about some research studies or projects you've been involved on?
A lot of my research projects were thrown off with COVID, but a lot of my research ended up being on COVID, especially with some of our neighboring counties. I was helping Lorain County with some of their projects in terms of a surveillance system, just looking at COVID. They had a donor donate to testing, and they were supporting Mercy Health. And we set up a kind of a surveillance system to actively look for COVID amongst students and staff. And we found that there was little transmission within the school, or that could be traced to the school. A lot of it was happening outside of school at home, but they were still enforcing a lot of the mitigation aspects that we see, like a lot of the spacing was still in effect, a lot of the masking was still in effect, and we saw very little transmission within the school with all that, and that included the bus drivers and all the staff throughout the system. And this was the entire school district, not just one school. So we were able to get a lot of good, meaningful data on that. Other research I've been doing has been more practical. So doing a lot of work that impacts kind of our management of primarily Hep C. So I'm actually traveling to Columbus next week to present on our Hep C implementation of training primary care providers in Hep C management, which we've been doing through the Ohio HAMP model, which is the Hepatitis Academic Mentorship Program. I haven't published anything on it yet because we're still kind of in the middle of it. And then I've been doing a lot of work with medical students on our, because I'm part of the global medicine pathway program through the Learner School. And so a lot of my patients have been doing, or a lot of my students have been doing projects on refugees through NFP, because it's a lot of our global health work has kind of was at a standstill with COVID.
Excellent, thank you. Maddie, you had a question?
So some have been saying that TB is on track to return to be the deadliest treatable disease. What do you think has been like the impetus, or like a couple impetuses of this?
I mean, I think I don't know. I have
Easy question, right?
Yeah, it's not an easy question. I think it's very hard to say because each community is very different. What we've been seeing in Malawi, we haven't seen so much multi-drug resistant TB, but we are seeing a lot of tuberculosis. But I think there's also a misdiagnosis. Like there's not a lot of great diagnostics that you can perform. And then when you throw HIV into the mix and the prevalence or incidence of HIV in that community can really alter what diagnostics and the sensitivity and specificity of some of those diagnostics. So you need a lot of trained clinicians in the field doing that, and radiology available. So I think the diagnostic part is hard enough, but then the case finding is often very difficult. But the amount of people and how easily it's transmitted is quite high. We do a lot of screening here for Northeast Ohio Neighborhood Family Practice sees all newly arrived refugees and newcomers into the region. And I can't off the top of my head tell you how many we are seeing with latent TB off the top of my head, but it is quite high. Most of the time we aren't seeing active TB because a lot of these people are being screened before departure and coming to Northeast Ohio or the US. But I can say that I think we are seeing a rise just because of, I think, the global world that we live in as well. And then I think HIV now in some of these communities the rates are very high. So we're seeing a lot more extrapulmonary TB and atypical TB as well.
And another question I had is, earlier on you talked about distrust and lack of inclusive spaces with historically excluded communities. How are you specifically addressing this and advice in addressing this for others?
So a lot of hospitals don't usually ask our advice on on how to make spaces more inclusive. But we have been, especially through the MPOX response, we've been working very closely with a lot of the LGBTQ plus community center, but also I've been fortunate enough to be included on the steering committee for a needs assessment that focuses primarily on the LGBTQ plus community that is being rolled out through Kent. So there's a researcher out of Kent that has done a needs assessment in his county and several counties around neighboring Summit, I believe. So we are trying to bring that into Cuyahoga County and expand that to other counties that were not touched initially in the initial needs assessment. So we are trying to do that. We do try to attend all meetings that might bring about these populations, and my wife also works at UH, and I know they've been trying to address that, and she works in the gender care team. Yes, with Christina. And so I know they've been trying to address how they do that, but each system addresses it differently. I think there's common themes, but I think each one has their own challenges in terms of which providers are in that space. Like if you have primarily the gender team within the OB department, it's really hard sometimes for people who may not identify as female to be coming into that space and being seen. So they're all trying to do it differently, but I think a lot of systems are adjusting and doing trainings for a lot of their providers, so they're more inclusive and use the correct language and screen for what, for example, what pronouns they should be using for patients.
If you were talking to someone, and let's just assume that this individual is new to the space, new to interacting with rural communities and just the topic overall, and the question is not necessarily why should I care, but more so what is the relevance? I'm serving the urban community, or I'm focused on what's local, what's right in front of my face. What would your response be to that?
Well, I think a couple things. I mean, a lot of the inequities that we see locally and we're dealing with in Cuyahoga County, we do see in more rural communities too. I kept coming across or thinking about place matters and the redlining that we've seen here that have impacted our Black communities and has affected everything from our infant mortality to what we see with our food deserts in our county. But I can't separate that from what we see in more rural communities too, where we also see a lot of lack of resources like food deserts, lack of broadband, for example, lack of providers. So I think that was one. The other thing that I would say is that, we are in a much more global or high, like very movable society now. What impacts what we've seen, when we were dealing with MPOX, I remember we were dealing with a few cases occurring in Western Africa, and then all of a sudden it was in Europe, and then all of a sudden it was in the US. And we've had people coming from rural communities or rural counties to get vaccinated in more central areas. So I think a lot of times this healthcare seeking behavior is hard to predict and impacts communities that we may not normally see and could impact you in your practice as well, especially now that telemedicine is much more prevalent as well too. Did I answer your question, Jalise?
Yes, it did. Thank you so much. And, I think that the state of mind when we're doing these READI special populations talks, a lot of us are already interacting with one or more of the populations in our research. And the purpose of it really is to get exposure to these different communities that we don't necessarily automatically think of when we're thinking of our disease topic or condition. So along the same lines, what is your take on mobile health clinics and their effectiveness in serving rural communities?
I think they're a great idea. And we are trying to get our own mobile van as well. But just from our experiences with COVID and Mpox more recently, being able to bring healthcare to the community or to where it's needed. We've been working with other agencies like the Cleveland Rape Crisis Center and the Renee Jones Empowerment Center that deals with a lot of women or people that are trafficked. It's hard to get them into the traditional spaces that we usually conduct healthcare, and just as we saw with COVID and everything, I think just our general way that we address healthcare and the appointments and all those things, it's not always conducive for everybody. So bringing a mobile unit or bringing medicine to the people versus having them come to us, I think may be the best way to reach hard to reach people.
You also talked about telemedicine. So with the digital literacy piece and health literacy overall, what are some tools and strategies that the Cuyahoga County Board of Health uses that could be implemented for our rural communities as well?
I mean, I think Ohio laws in terms of telemedicine has helped. I think they've been a little more lenient and progressive on that in terms of who we can see and bill, and that's transformed a lot of clinics. Where I practice at Neighborhood Family Practice also was an early adopter of a lot of these, taking advantage of a lot of these laws. But the health department, we've also been able to do a lot of telemed types of care, and it's been very helpful in terms of making sure we're able to establish some kind of care with patients. It's come up a couple of times, especially with some of these syphilis cases that we've had when chasing them down, and they can. We had a pregnant woman. She was a sex worker, I think, in Lorain County, who was tested positive for syphilis, and she didn't have an established provider. She was also pregnant, and we needed to get her treatment. And just having that telemedicine option kind of helped her get connected with us. We did drive out to her and meet with her and treated her 3 times. But that was just one example of how it's been helpful in terms of just making sure that she had some kind of established care, just having that telemed option.
Fantastic. Thank you. Do we have any other questions in the chat, or if someone would like to come off of mute?
It's good to see some familiar names and faces.
In terms of collaborating with the Cuyahoga County Board of Health, what would be the first 3 steps that a researcher should take towards building relationships and really jumpstarting a project that meets the needs of and priorities of the organization as well as the communities to be served?
I mean, I think some of the people on the call could give some good feedback on that. But I think reaching out, I think our new health commissioner, he's been there for about a year now, Dr. Rod Harris. He's very open to trying to brainstorm and provide support for projects that are serving the community, and especially in communities that are more marginalized. Both him and I started together about a year ago in our positions, and we've already seen several things come and go, such as Mpox, but then concerns for measles, vaccine hesitancy. That's just to name a few, but he's very, very willing to help support projects that look at those types of things, and especially impact our more marginalized communities. So if you were interested, I think reaching out to myself, or since I'm connected to Case, I think it's easier to reach out to me. But I can also get you connected with Dr. Harris, and we can figure out ways to collaborate. And if you need a letter of support for a project, that we would be happy to. And then I can also connect you to other people that have, like our EPI teams or our environmental health teams or clinical teams that can help support. Because as a physician, I don't often know those spaces as well.
You mentioned a couple of different disciplines there. So in public health, and when we think about its relationship along the translational science spectrum, being one of the 5, it is really great and refreshing to hear about all of the different disciplines that are needed to effectively meet public health needs. And when you mentioned the LGBTQ plus community health needs assessment, I'm also on a couple of those groups too. So it's really fascinating to see the possibilities and the insights that will come from that assessment. Do you see any other opportunities for community health and needs assessments with other special populations?
We haven't initiated any. A lot of the needs assessments that are being conducted are through the CHINA and CHIP that are required, that we're collaborating with the hospital systems to align. But I haven't seen any other initiatives come out to look at other specific populations that are outside the context of like vaccine hesitancy or something like that. So the needs assessments that we have done or are doing are more situated around hesitancy with like vaccines, for example, outside of the steering committee that we're doing, or the needs assessment we're doing for the LGBTQ community.
Okay, thank you so much. It looks like we have a comment in the chat about, the AAPI community assessment is now being conducted with the support of the Cuyahoga County Board of Health. That's fantastic.
Yeah, so Dr. Glavin had reached, we had worked together. It was more a vaccine hesitancy assessment initially, I remember, and then it's evolved. But I've been outside of the discussions on the more evolved project that's taking place now. But I think I'm going to be involved in a few weeks' time, from what I've heard. Right, Dr. Glavin?
All right. Well, thank you so much, Dr. Ganesh. And let's talk a little bit about what's next. We will have our 5th talk of the year. We'll be focusing on disabilities, communication disorders, and the deaf, hard of hearing communities on Friday, May 26th from noon to 1, also on Zoom. And we will have an American Sign Language interpreter on the call. What can you do today? You can schedule a READI consultation at spark.case.edu, sign up to attend future programming, be sure to join our listserv. And then we also have some excellent CTSE DEIA resources on our website. We're going to give you a few minutes for some virtual commute time. I know this is the lunchtime, so hopefully if you didn't eat during the call, you'll have a few minutes to grab something before your next meetings. And we thank you so much for joining us, and we hope to see you next month. All right. Have a great afternoon, everyone.
Thank you. You too.
Thanks.
Great,
Bye.
great session.
Thank you.